One.
Good afternoon, everyone. Thank you very much for joining us for what we hope will be a really interesting discussion about the challenges and triumphs of community rights and gender approaches to tuberculosis in Southern Africa. As many of you know, there is a commitment from countries all around the world as a result of the United Nations high-level meeting on TB to integrate and address community rights and gender in their TB responses. There are a number of tools that are available to help and support communities to do this. These include things like CRG assessments, stigma assessments, community-led monitoring, and scorecards. A lot of this work has seen significant progress in a number of countries from across this region, including South Africa, Mozambique, Zambia, Malawi, Zimbabwe, Angola, amongst others. And I think through the discussions of our speakers today, and we have Mzingo, Perez, Ivaristo, and Rachel with some messages to share, we'll understand as well about a number of the opportunities, but also the challenges and the next steps that countries can take to help realize an equitable and human rights-based TB response. A response that can help all people, even key and vulnerable populations, overcome barriers to accessing TB services so that we can ultimately find all the missing people with TB and end the TB epidemic. Now, with that, I would like to hand back over to the recording of our first speaker to share some of her insights. Thank you so much.
Hi everyone, my name is Ntisunge Mkonopili. I work for DAP Malawi, that's Development Aid from People to People under TB Loan 2 project. I'm here to share with you information on integrated pathways and interventions to reduce the effects of stigma among TB patients and at-risk communities in Mulanje, Machinga, Mangochi districts of Malawi. So in Malawi, we have 27,000 cases of TB, and according to data for 2020, 56% of patients were enrolled on TB treatment. And out of those who were enrolled on TB treatment, 87% finished treatment, which was still below the targeted 90%. You should also be aware that Malawi is a high-burden TB HIV country. So as of now, 46% of TB patients are HIV positive. Why is TB stigmatized in Malawi? So according to the survey that the project conducted, it was found that TB is associated so much with its danger of transmission. So the TB patients are considered to be very infectious and dangerous. People also stigmatize people who have TB because of the link between TB and HIV. So they think those who have TB deserve to suffer from TB because of the risky sexual behavior of HIV positivity. And also they associate TB with alcohol use, smoking, poverty, low social class, and malnutrition. So as a project, we have introduced multi-coordinated interventions for TB stigma reduction among healthcare providers, TB patients, and communities. And the interventions include creating awareness of risks, symptoms, transmission, prevention, diagnosis, and treatment, and also the correlation that is there with HIV. We have established TB knowledge base in the community through training key community stakeholders on TB and stigma reduction, and also through the CAP survey. And on the problem of treatment non-compliance, We have supported the formation of treatment support group and those families which have patients, TB patients. So now we are supporting them to informing support family members to help them to adhere to treatment. We have built the capacity of community health workers and volunteers to provide follow-up care and also psychosocial counseling and encourage the patients to adhere to treatment. We have trained the community health workers and volunteers on stigma reduction. We have also identified and engaged community stakeholders in effort to end TB and stigma through comprehensive community stakeholders. We have developed and rolled out a TB stigma human rights and gender community communication strategy. We have revamped and provided technical and logistical support to District TB Forum, who are given responsibility to solicit and facilitate response and action on TB and stigma-related issues. We have established and rolled out TB community-led monitoring and built the capacity of community and religious leaders on issues of TB and stigma reduction. We are tackling stigma among healthcare workers by implementing the KNCV Allies approach, which aims to change the attitudes and workplace conditions of healthcare workers to enable them to provide empathic, non-stigmatizing care to all TB patients. We are also involving knowledge and enhancing workshops targeting the healthcare workers in the project participating facilities. So the results of these interventions are that there is increased awareness about the disease and its cure, leading to more people willing and accepting to be screened for TB in the communities. There is also increased success rate as of now the treatment. There's also increase in treatment success rate. So as of recent, the treatment success rate in the three districts has been 88%, 86%, and 85%, which is higher than the previous years. And also, due to the interventions being implemented, we've had patients disclosing to their family members of their status, and we've had more patients who have completed treatment. Like for the patient we were able to visit, 100% of the patients completed their treatment, and even some patients who were lost to follow-up have completed their treatment. And also the community leaders have helped to introduce bylaws against those who were found in certain TB infected individuals or TB affected individuals. So as a project, we have recommendations after this period of implementing the project. So the recommendations are that we should, in this area of stigma and discrimination, we should empower and engage people affected by TB in the drive towards ending TB-related stigma and discrimination, and also review messages and strategies used for improving awareness, because these messages are not incorporated, the stigma and discrimination. And also we should find ways to measure stigma-related intervention outcomes and impact at the national level. Because as of now, we have interventions, but there hasn't been any measure on the impact of such interventions. Thank you. So these are the references for the presentation.
Hi everyone, I'm Pirish Nota from ADDP Mozambique. Currently, I'm working as a provincial coordinator in Mozambique local TB response with the project funded by USAID, which one impact community-led monitoring is being implemented in Zambezia province. Now I'm going to talk about one impact and the community-led monitoring. It starts with the people, not the disease. Well, as we know, uh, in spite of the progress, TB continues being one of the major health concerns. In 2020, 97,093 people were diagnosed with TB all forms in Mozambique. The TB incidence is 361 per 1,000 inhabitants, where 12% are TB pediatric. And there continue being many missed TB detention among children and adults. From 2015 to 2020, the country saw impressive progress, but significant barriers remains. For example, we have the stigma related to TB, HIV, high-risk group, human rights violation throughout cascade of care, gender inequality, sitting capacity gap. Also, the access to TB service is a major challenge for the majority living in rural areas, which the long distance to health service. In spite of progress with gene expert diagnostic capacity, only 33% of the diagnostics are pathological confirmed. ADPP Mozambique is a local NGO founded in 1982, operating at national level in the country, promoting a people-to-people approach. ADPP Mozambique piloted One Impact community-led monitoring in 2019 with 100 people with TB in Maputo province, in 2020 in Gaza province, and now is working to scale in Zambezia and the Maputo provinces. One Impact community-led monitoring is a digital platform that allows people affected by TB to learn more about the TB and human rights. Also, to report any barriers experienced in fulfilling their rights to health, involve the community to take part in resolving issues. Also, to understand that stigma and discrimination are not the norm, and it can change, and they can advocate for corrective actions. One Impact or community-led monitoring, it provides a real-time data on the provision of right-based TB service, opportunity to take immediate action to resolve reported issues, also give a quality evidence for strategic planning, also give a framework for rights-based people-centered care. This slide want to show the result from June to September 2022, where 1,641 people reported issues, barriers and challenge, where 41.6% were women and 58.4% were men. So we can see that 36% were highest reported barrier, that is a barrier related to the health service. Also, we had another highest reported barriers or challenge, where we had 38% was barriers related to stigma. And asked what social support they would like to have, people affected with tuberculosis responded with 35% for nutritional support and 30% for psychosocial and 30% for financial support. In terms of insights and recommendation, we have had the issues, and also we have issues what have been reported. For example, family member of a person with TB is not screened. This was the issue much reported during our pilot phase in Maputo. Because it was reported, we could organize action, come back to the household and screen the family members. And as a result, more children were found eligible to start TPT, a preventive treatment of tuberculosis. Also, in Morumbala district province, Zambezia province, a person affected by tuberculosis reported a barrier that friends and the neighborhood treated him differently because he had tuberculosis. As a solution, the activists communicated to local leaders to organize a lecture in that area and invite the people to have this message of awareness. So on the day scheduled for the activity, the case manager together with the activists gave a lecture on stigma and discrimination in the people affected by tuberculosis and other disease to raise awareness among participants. So we can see that stigma reduction needs to be in the high agenda of TB responses. Also, psychosocial support and the nutritional support is fundamental for successful treatment adherence. So, community engagement is a key for mobilizing support, also resource and improving experience for people with tuberculosis and therefore tuberculosis outcome. Gender inequality is a significant challenge for women affected by tuberculosis, which can be addressed by more investment, engagement for affected communities. Also, there's a need training of human rights and gender for community activists and health professionals, which increase capacity to analyze reported barriers and provide better service. Finally, for expansion, it's good to have a huge potential to support people centered, support people centered, evidence-based strategic development, guide resource allocation, and increase progress toward NTB targets. So also there is a need for opportunity to leverage civil society to scale and expand one impact national. For me is Kate to present Party F from Mozambique. Thank you very much.
My name is Evaristo Waya from ADPP Angola. ADPP is an Angolan NGOs working with the 4 different sectors with education, health, agriculture and environment, and also Indian developments. The main sector is education with 15 teacher training college and the age polytechnical and vocation training, and also is a founding member of the Federation Humana People to People. And as I said, ADPP supported the national TB program to develop the TB community strategy. And according to WHO data, Angola is a burden country for TB, which estimated the incidence of 350,000 or 350 per 100,000 population, which represent 4.4% reduction if we compare 2015 to 2020. The treatment coverage is 55%, and the coinfection rate TB HIV is 12%. And also the data from WHO informed that 71% of people living with TB know their status, and about 67% on treatment, on ARV treatments. And the success treatment rate is 69%, and the case fatality rate is 19%. And also we can see that 65% of national programming unfunded, 21% is from domestic funds, and 14% is coming from international funds. And the objectives of the strategy The purpose of the community strategy is to provide the context, the challenge, objective, intervention, and the roles of stakeholder in national TB response, to define the activities that will contribute to the prevention, diagnosis, treatment, adherence, and the care of people with TB in a way that positively influence treatment outcome and reduce mortality. And also, one of the strategic objectives is to provide a framework for the coordination across system stakeholder for community-based activity. And the other objective is to identify gaps in the implementation, in the implementing people-centered care, especially in the community involvement, and also to outline the means of address this gap with measurable indicator of progress and achievements through community actors. The strategic result of this community strategy support the national TB program in achieving the goals indicated in the national TB strat plan in accordance with the global plan to end TB by 2030, namely reduce the death from TB by 90% and reduce the incidence of TB by 90%, and also reduce catastrophic TB cost to patients and their family to zero. Why a community TB strategy for Angola? Supportive of integrated people-centered care and support, media messaging to increase awareness, conducting systematic screening for TB case funding, recognize and support the role of community stakeholder, strengthening sputum collection and transport system using outreach work, and support orient family and community-based treatment support, and also developing peer support group and improving food practice through nutrition awareness. How the community TB strategy for Angola develops, and we want to share with you that with leadership of National TB Program, the community TB strategy was developed with the participation of different stakeholders from National TB Program, WHO, UNDP, UNICEF, UNAIDS, USAID, PEPFAR projects, NGOs such as ADPP, QUAM, CVA, ANAS, and the SICA, and also participation from different TB health facilities. And in conclusion, we can share with you that the theory of change demonstrates the path to be taken by the National TB Program in partnership with the non-stakeholders to support the reduction in TB incidence, reduction in TB mortality, and zero catastrophic cost. And also it is expected that through effective implementation of the community strategy, the Angola TB program will be able to achieve improvements in treatment, outcomes, evidence on the community-based care system, and challenges in policy and national level to ensure that people-centered approach are utilized.
Greetings to all. I'm called Rachel Ngum. I work for Humana People to People as the project leader for the Reduced TB project that is funded by USAID. Thank you for the opportunity to present at this very important forum. My presentation is about gender assessment and action plan for improved TB outcomes. The project DRC is one of the countries with the high burden of TB, drug-resistant TB, and TB HIV/AIDS. The country is among the countries that signed for the Moscow Declaration to end TB by 2035. And the country has adopted the SADC vision for TB-free region, zero deaths, diseases, and suffering due to TB. In 2021, the estimated incidence for the country was 318 per 100 population, but what was realized during the year was 219 patients per 100 population. The TB HIV co-infection rate was 8%, and the treatment success was 94% for new and relapsed patients, and 83% for drug-resistant TB. In the country, men are the more affected and represent 51% of cases, while women represent 38%, and children from 0 to 14 years represent 11%. The Reduce TB project is a 5-year project that is implemented in 3 provinces of the DR Congo. And the provinces are Okatanga Province, Holomami Province, and Lualaba Province. The 3 provinces have a population of 14.8 million population and is divided in 57 health zones, 222 health facilities that offer diagnosis and treatment, and 680 facilities that offer just treatment. In 2021, there were 14 gene experts to serve the 3 provinces, but the situation has changed as more gene experts have come into the country and have been shared across the provinces. Reduce TB is a community approach, works with a community approach, and it's a patient-centered approach where the patient is at the center of all. And we have to do this, to do the active finding. The objective of the project is mainly the active finding of all the missing cases in the communities. And we have field officers that works with community health workers, and they are attached at facilities that does diagnosis and treatment. And the field officer and community health workers are there to do contact investigation, to do tracing of lost to follow-up patient, to do sensitization around the community awareness campaign. They are also there to screen patients, refer them to health facilities, and collect and transport the sputum to health facilities to be diagnosed. And then we have the nurse at the health facility that initiate the diagnosis, that initiate patients on treatment, and that also initiate investigation at household. And all this approach are in line with the national TB program, with the different provincial coordination. We work together, and the capacity of community health worker, of the health provider have been built. They have been trained, community leader as well. So together they can bring in all the support that is needed to ensure that new cases of TB are diagnosed in the community. The people have been put in treatment, and they have been supported to adhere to their treatment and successfully finish their treatment. At the beginning of the project, we did an assessment to see how TB affects the different gender. And here are some of the findings. We have categorized them for men, women, and for children. For men, there is high occupation and behavioral risk. There's avoidance of health services seen as women space and long waiting time. Men, they don't want to wait. Cause and diagnose for treatment, the payment, fear of losing livelihoods, different treatment, difficult in treatment adherence. Most of them, they don't finish their treatment and they become resistant. There's also stigma discrimination, the fear of loss of employment and divorce in some cases. For women, we have higher environmental and biomedical risk. We have a burden of care. They are the one that care for the family, for the sick. Delay health seeking due to household responsibilities. Long distance to health services. Cost of diagnosis and treatment. There's also stigma and discrimination. gender-based violence, marriage prospects. And for children, there's high malnutrition rates that causes children to be vulnerable. Dependence on parents, awareness and responsiveness, cost of diagnosis and treatment, stigma and discrimination at school and in community, limited capacity for health workers in pediatric TB. The project has tried in its own way to address some of these barriers through its community-based approach, and this is by training community-based health workers on gender and human rights related to TB stigma and discrimination, awareness raising in high-burden community on TB stigma and discrimination, provision of community-based services to address access to accessibility barriers, formation and training of home-based treatment adherence support through trios, actively involving men and women to share burden of care, adopting outreach and activities to men and women time commitment. During the first year, some of our results, the project started in the whole Katanga province before expanding in the other provinces, the community contribution has increased in the whole Katanga province from 19 to 33%. The new TB cases notified through the community door, through community that has been orientated from the community for the year was 6,814, which with a yield of 13%, that is higher than the 10% national norm. We have 95% of these patients put on treatment, and 82 of them, we constitute trios around them, and 98% were tested for HIV as well. So we have an approach where when the patient is notified TB, he's immediately tested as well for HIV. For drug-resistant TB, presently we are at 1%, which is low than the norm that is 2%, and this is due to various reasons. Eligible children, under 5 children to be initiated on treatment is 87% that have been put on TPT. And here also there are various reasons of drugs, availability of drugs, mainly in the rural areas and in some facilities. The health provider who are not well trained on pediatric TB and so on and so forth. We have around all our patients, around 3,386 trios have been formed around the patient. We have trained in the 3 provinces 1,658 community health workers with whom we are working, and we have also trained and involved 896 community leaders to work with us. And here are some recommendations. There is need of more target support and fund to better understand the way gender affects TB outcomes in the different contexts of DRC. DRC is very vast, and in each of the province, there is a different way. There are different ways where TB affects gender. Development of gender-specific indicator in the TB to be monitored. This is for the national TB program. Indicators they are working on that, but they need to be developed and shared so that each partner can work towards achieving this indicator. Systematic capacity building of health provider on gender and human rights related to TB. This is needed. Multi-sectorial referral between health, social, and for people affected by TB due to multifacial experience of stigma, the trend of losing employment, housing, marriage, schooling, etc. There is also need of increased focus on resources at all levels to reduce catastrophic costs in TB, including monitoring. Thank you for your your attention.
So I wanted to now just to say up front a big thank you to each of the speakers for their presentations. Rachel, Misungu, Perez, Ivanisto. It was really important, I think, to hear your rich and diverse experiences from across the four countries, from Mozambique, Malawi, Angola, and DRC. Obviously, one of the things whilst it was very unique angles and areas of focus, there was also some common areas and some areas I think of shared interventions. I guess maybe that's also linked to being part of the Humana family as implementers. Some of the things that I think we heard a little bit about was assessing community rights and gender related barriers, whether it be the gender assessments or CRG assessments or stigma assessments. Additionally, there was a little bit of work or focus areas looking at monitoring of human rights related issues. And I think there was some discussion here around stigma, but also community-led monitoring in particular. And I note the Mozambique experience in particular here was something that I think was really, really valuable and important. Beyond that, I also heard quite a lot around people-centered approaches, around peer support and psychosocial support, and the critical role that this plays in having strong, inclusive, empowering TB responses at the country level. I think as well there's the really interesting discussions around the different stakeholders that were engaged to really make all of this work to be effective and to be really important. And so that's certainly something that I think can be really important to all our audience and listeners here. So, having heard those presentations, it would be really good to see if there are any particular questions from colleagues who are listening and who are participating today that we can further discuss as a panel. But while we're waiting for those to come in, one of the things that I would really like to hear, and I see Perez and Rachel online, what do you sort of see as the next steps? What are your next priorities to continue to take this work forward? We know that obviously there's been work around assessments or community-led monitoring, but how do we scale that up, or how do we operationalize the findings of those reports a little bit further? So, maybe I go to Perez first and then to Rachel to just hear your responses. And then if there's other speakers online, we'll go to them immediately following that. Perez.
Thank you, James. Thank you, everyone. I think for Mozambique, we're trying our lot to scale one impact to all country. Also, we're trying to mobilize another organization to put more funds, because what we have as experience here in Mozambique, we started in Maputo province, and went to Gaza, and now we are here in Zambezia. In Zambezia, we started, for example, last year with 2 districts, and this year we went for more 2 districts. So we think that this community-led monitoring is very good and very important, because we put the people who are suffering with tuberculosis in center, because we want to eliminate tuberculosis. Also, we are involving different local leaders, for example, to support us on mobilizing the people in the community to start the treatment area. Also, we are with this one impact or led in the community, we are involving the technician of Ministry of Health to also to be involved. As we see in this project, TB response, we're working with the activists. The activists, they are going house by house to mobilize the people, to know what they have to do to prevent the tuberculosis disease. So also we're giving these lesson lectures in the community to people to give the people the awareness. So this is the way are we doing here in Mozambique. Also, ADP is working with the Ministry of Health to open lines, for example, to choose this WhatsApp. Anyone can ask the question, any patient can ask the question, they can be answered. For example, the issues according to stigma and other issues. So this, what are we doing to involve more people? So to make it for all Mozambique, not one part of Mozambique. Thank you very much.
Thank you so much, Perez, for that. I think it's really, really clear from what you've shared that we have a very clear approach to community-led monitoring for TB, and that is now going from strength to strength in Mozambique. And one of the key messages that we can take away from this, and to link the idea of CRG, or community rights and gender, to the work of national TB programs, is that through community-led monitoring, we are identifying barriers. We have communities engaged to find quick solutions, and we're helping people to get on treatment earlier and continue their treatment. And this is why it's such a critical intervention. So thank you so much for sharing. Rachel, now for you, the same question. What do you sort of see as the next steps to help operationalize all of the great work that you've been doing? Over to you, Rachel.
Thank you very much for the opportunity. I think for us, so far we are working in 3 provinces. And we have noticed that there is much more tuberculosis in the community than we think. Initially, we had some goals, some targets, but only after 18 months of a 5 years project, we have already reached 52% of the new TB we were supposed to find, and now we have adjusted our goals and targets. And we think the community aspect is very important in winning TB. And here we have to involve all the parties. We have to mobilize all the community leaders, all the community volunteers and community members to be part of the active finding of tuberculosis in the community. We know our country, DRC, is very well organized in terms of strategy and planning, but the reality on the ground is not that. The reality of the ground doesn't match what is planned, the strategies and all. So more need to be done, because all the patient, they are sitting at the community, and it's not just finding these people, it's also organizing them in such a way that there is very good response on how they go on to take their treatment, they are there to the treatment in order to prevent the infection in the communities. And we also think this aspect of gender I was talking about plays a very big role. And at the national level yet, there are not clear indicators that can help respond to some of these challenges that patients face in their daily life, in their daily home, in their homes, and in the community. So there is a need also that the national TB program sits and put together those indicators and better strategies, how these people are affected with gender-based violence, that are victims of gender-based violence, that are women that are being sent out of their homes because they
Rachel,
have TB. Yeah.
Rachel, can you able to just wrap up so that we can hear quickly from Masingu, just because we're running out of time? Thank you.
What I'm saying is that, all the community has to be mobilized in such a way that we find a response to TB in the community. Else it becomes difficult, because all the patients are sitting in the community, and the best way to win it is to prevent TB from spreading in our communities. Thank you.
Thank you so much, Rachel. Love the talk of M&E and indicators and multi-sectoral engagement. And Masingu, you finally got it. We finally got you back. Do you want to just make a 1 minute sort of intervention on some next steps for you and your project? I think you're on mute.
So as already indicated in the presentation, the interventions that we have in regard to stigma and discrimination, we have a number of interventions. So basically, we are having interventions in the community and also at the facility. So at the facility, we have an ARES approach. So this is an approach that has been brought forward by KNCV. So they trained our health personnel. Actually, we organize coordinated workshops among the health workers so that they change their attitudes towards patients with TB. So in this workshop, what really happens is that these health workers, they are supported in terms of trying to assess themselves internally on their attitude towards TB patients. And also they do coordinated interventions. So they work together with the health workers. They work together to identify the issues that they have pertaining to stigma and discrimination. This is in a way that how there are values in terms of stigma and discrimination, how they would treat a patient as individuals, and also they are compassionate towards patients living with TB. So this intervention, this approach helps these health workers to be able to assess themselves where exactly they are, and also support them on how they can change their attitudes towards the patients who have TB.
Thank you.
For the community interventions.
Sorry, Mzingu,
So
we're actually at time. So I've just been told that we've run out of time. But I think your last message was perfect, just to really emphasize the importance of working with communities. And given that we're at time, I think that it's a shame because could have been like we could have kept talking for a long time. But I wanted to just, before we wrap up, thank Rachel, Mzingu, Pires, and Evaristo for sharing their amazing work. And to say next year we have a UN high-level meeting on TB. We need to ensure very strong commitments for community rights and gender interventions and ensure that there's funding available so that the type of work that's being discussed here today can continue to be scaled up and that more communities can continue to be champions and lead the TB response. So I wanted to thank also the audience for joining us today. And again, to our speakers, your work is amazing and it was really wonderful to hear so much about your incredible efforts. I would encourage everyone who's listening to contact our speakers to hear a little bit more about their initiatives and continue this conversation. So thank you and have a lovely evening.
Thank you.
Thank you.
Bye.
Thank you.